I currently work at the Walt Disney Company as an environmental associate on the enterprise and social responsibility team. I'm still very connected with UC Irvine, and I serve as a board member on the UC Irvine Public Health Alumni Chapter Board, in which we're actually celebrating our first full year as a chapter. The UCI Brilliant Future virtual event series was designed to create a meaningful dialogue addressing challenges and issues created by a rapidly changing environment, specifically during the time during COVID-19. We've explored timely topics, including voting rights discussed by UCI law professor Rick Hasen, as well as a talk exploring student success and the future of higher education presented by UCI Vice Chancellor of Student Affairs Willie Banks and UCI Vice Provost of Teaching and Learning Michael Denon. I'm really thrilled to be moderating today's panel, but before we begin, I do have a few housekeeping notes. Today's program format will feature 3 distinguished speakers giving brief remarks followed by a conversation and Q&A. Audio for all attendees is muted, so please type in your questions for the speakers in the Q&A box. This event is being recorded for participants, and a recording will be made available on the UCI Brilliant Future website. It is now my pleasure to introduce our first speaker, Dr. Bernadette Boden-Albala. As Director and Founding Dean, Dr. Boden-Albala will oversee and guide the development of UCI's School of Population and Public Health. An internationally recognized expert in the social epidemiology of stroke and cardiovascular disease, Dr. Boden-Albala specializes in the design of strategies for prevention and preparedness and has produced a wealth of knowledge on stroke avoidance. Having previously served as a Senior Associate Dean of Research and Program Development at the NYU College of Global Public Health, Dr. Boden-Albala created courses with UNICEF and the United Nations World Food Program. She has also developed the Cross-Continental MPH, a 1-year program that combines classroom learning, collaborative research with faculty members, and public health practice experience across 3 continents. Please give a warm virtual anteater welcome to Dean Bernadette Boden-Albala.
Thank you very much. So I just would like to open my remarks by thinking about the title of this series, Public Health, the Way Forward. And I think we'd all agree we are in unprecedented times. And these are the times when the role of academic public health becomes really critical. Our program, which is in transition to a School of Public Health, has been at the table from the earliest conversations around what was initially a strange virus from China, moved to coronavirus, and now, of course, COVID-19. Our earliest efforts were around preparedness for students, staff, faculty, and the community at large through talks just like this one with Dr. Neumer and Dr. Parker and others. Our researchers have highlighted effective health communication methods, and we talked a lot about the importance of behaviors and of social policies that reinforce these behaviors. UCI Public Health partners with the Orange County Healthcare Agency early and brought in modelers to understand the nature of the epidemic and prepare for early surge and peak. Together as a community, though, we didn't experience that surge and peak, and instead we flattened the curve, and for a solid 8 to 10 weeks, this curve held. But as we in Orange County watched the slow growth of COVID here, we also saw the unveiling of disparities across the nation and in Orange County. We saw rates of depression and domestic violence increase. We saw a declining economy and racial injustice throughout the nation. In Orange County, our social policies relaxed, and very, very quickly we moved out. And unfortunately, our cases are on the rise again. We continue to partner with Orange County and community organizations in efforts like health equity-based contact training workshops and surveillance studies. And we continue to make predictions about this unparalleled virus, which seems to ebb and flow. And I finally like to conclude that while preparedness is critical and vigilance, which we'll talk about tonight, remains the mainstay, we know a lot more about COVID than we did in early January and February. And so we talk more about vaccines, about prevention, and about resiliency. I know we're in a difficult balancing act here in Orange County, but the UCI School of Public UCI program in public health is really here to work with community, and together we're going to be able to get through this. Thank you.
Great. Thank you so much, Dean Boden-Albala, for your invaluable insight and comments. And now it is my honor to introduce the second speaker for tonight's event, Dr. Andrew Neumer. Dr. Andrew Neumer is an associate professor in public health at UC Irvine. His research focuses on health and mortality, the 1918 influenza pandemic, demography methods, mathematical sociology, and more. He earned a BA in biology from Harvard, a MSc in medical demography from the London School of Hygiene and Tropical Medicine, and a PhD in sociology from UC Berkeley. Dr. Neumer has been recently quoted and interviewed by local and national news outlets, including The Atlantic, CNN.com, LA Times, Newsday, and the New York Times. Playfully nicknamed Professor Dark Cloud, Dr. Neumer has quickly risen to the top as an expert during the COVID-19 outbreak. Dr. Neumer is also one of my favorite professors at UC Irvine, so it's really nice to be back. Please join me in giving virtual applause to Dr. Andrew Neumer.
Thank you, Natasha. It's great to be here. Thank you all for joining us this afternoon. Thank you for supporting UCI program in public health, especially now during the COVID crisis and as we transition to becoming a school under the leadership of Dean Bernadette Boden-Albala, from whom you just heard. And a special thank you for my former students who are joining us this early evening. I saw the guest list, and I saw a bunch of my former classroom students, including yourself, Natasha. So thank you all for joining us. It's great to see you again. I'm asked all the time about predicting the future of COVID. You know, when will cases peak, and will there be a second wave, and you know, when will we be able to go back to normal? And the most important aspect of my answer to those questions, and essentially any question involving predicting the future of COVID, is nobody knows, because the answer depends on you. Whether we mask, whether we socially distance, you know, all of these things will shape the future of the epidemic locally, nationally, and globally. And it's impossible to say, you know, if this is a summer lull, if there will be a fall wave. You know, there won't be a fall wave if everyone masks and if we do our best to maintain social distance, but there will be more COVID, you know, in all of our futures if we don't do these things. So, you know, I mean, there are certain things we can try to make informed guesses about. There are certain things we can try to model. There are certain things we can try to forecast, but nobody knows the exact future course of this epidemic. And the most important thing I would say in my introduction is just nobody knows, because it depends on our actions. So let's act smartly. And that's all I have for the intro.
Awesome. Great. Thank you so much, Dr. Neumer, for your enlightening and thought-provoking remarks. Our third speaker for the evening is Dr. Daniel Parker, Assistant Professor in Public Health at UCI, as well as the Director of the GREAT Program, a student global health initiative within the Department of Population Health and Disease Prevention. Dr. Parker's research focuses on spatial epidemiology, especially of infectious diseases, spatial demography, and global health. He earned a BA in anthropology, as well as a certificate in medical anthropology and global health from the University of Washington, Seattle, and a dual PhD in anthropology and demography from Pennsylvania University. I've been very familiar with Dr. Parker's work, and I'm really excited to have him today. Ladies and gentlemen, please give me a huge virtual welcome to Dr. Daniel Parker.
Thank you, Natasha. I'm happy to be here and excited to have all of you here. Actually, what I'd like to do is share my screen so that I can show some maps. Actually, because this is what I spend a lot of my time doing. Okay, so what I want to do is I want to show the distribution of reported cases of COVID-19 in Orange County at the zip code level over time, so we can kind of see how this how our epidemic, or the epidemics that are combined within Orange County, have kind of evolved over time. And to orient you to these maps first, I've got the legend here. So this shows you the color scheme that you'll see on the maps. It's the number of reported cases per 100,000 people per week, and low cases are yellow, and the dark cases are in the dark blue or purple color there. Right? So the epidemic here really started mid-March, and you can see at the beginning, the darker colors are along the Central Coast area. So these are places where, these are places along like Newport Beach, around Laguna Beach, Corona del Mar, those areas. But as the epidemic kind of progressed, as we move along in time, you can see that it shifted. The overall cases went up. There's a little bit less of a detectable pattern in April. But as we move into May, you start to see a hotspot developing up in the north central area. So that's around Santa Ana. And here we are in June, or working our way almost all the way through June, and we've got two pretty clear hotspots, maybe one large hotspot developing up there in Santa Ana and Anaheim area, and that's where we are today. And I think it's important to kind of think about what are correlates, socioeconomic correlates, with these spatial patterns. So those places where the epidemic started off, those are kind of our affluent communities, right? So these are places where you have lots of wealth, lots of expensive houses, and the reasons that it may have started off there are probably complex. But it could be related to travel, to international travel. It could also be related to access to testing. If you remember at the beginning of this epidemic, it was hard to get tested, and it may be that if you were in a place where you could afford private doctors or people who had better access to testing, that you got it first. But now, where that hotspot is centered, these are the most population dense, low socioeconomic status parts of our county. And so really this is a story of two different epidemics, I would say. And now we've got, and also tied in with that, you can think about social distancing. It's probably, I think it's safe to say that if you're independently wealthy, if you have a job like what I have the fortune of having, where I can work from home from my computer, it's easier to socially distance. If you're putting food on the table through hourly wages, then it's not so easy to do that. So that's what I have for you.
Great. Thank you, Dean Bodenholt-Bala, Dr. Neumer, and Dr. Parker for your precise and pithy presentations. It looks like we have a couple of questions already in the Q&A box. And as I mentioned before, you are all muted. However, please write out your Q&A, your questions in the Q&A box. So I will go ahead and ask the first question, which is, how do we continue to stay alert when businesses are opening up? It seems like the question he asked about complacency and rationalization, so those are along those lines. And I'll open it up to all the panelists.
Well, I mean, I would just say, wear a mask when you go out in public, some sort of nose and mouth covering. And I personally, I think good faith advice from me is what I'm doing, which is still going to businesses only when I have to. So certainly I go to the grocery store because we all need to nutrition, and it's not something I worry about, but I do mask up when I'm there. And there is now a statewide masking order, so in theory we're all sort of supposed to do that, the masking anyhow. But I don't go to businesses that are not essential to me. So I don't go to browse records or something. I'll do that later when it's safer. And we're still in a pandemic, but we are opening up. We can go out more, but just masking is really the name of the game.
So I'd like to add to that. I think that absolutely, Andrew, totally spot on. A couple of other things I think that you could do is, figure out a time to go when you know it won't be as crowded. And one of the things, you can drive by the business, and if it looks like it's crowded, a lot of people are in there, try to find a time when it's less crowded. That's the first thing. Don't be afraid to ask someone who works for the business, what are you all doing? I was purchasing a kitchen sink the other day and walked in, and it looked like it was really set up. It was appointments only. I had an appointment. I checked it out on the phone. I spoke to them. What are you doing? And then even when I was checking out, they were telling me that they took their temperature every day. They did monitoring. They had to wash their hands after every encounter. So don't be afraid to do that. So I think, and then whatever you can do, be outside as much as you can. So if you're going to a restaurant and you're in a mask, and we know that eating is a time where there's a lot of vulnerability. People often eat and talk at the same time. Try to stay outside if you're going to do that. And then, just so you know, that the CDC basically has regulations for every kind of industry. And so there shouldn't be a business out there that doesn't know at this point what to do.
Yeah, I guess I would follow up with, I would echo what both Dr. Neumer and what Dean Bernadette have said, and say you don't need to spend all of your time indoors. Exercise is still important. You still need to go get food. Just be careful, be safe, practice hygiene. I still go out and exercise, but if I'm going out to the hiking trail and it's looking pretty packed, I'll go back home and I'll wait for another time.
Great. Thank you both. Thank you all so much. So moving on to another great question from the Q&A box. Do you think this will get worse during the colder months? And a follow-up question would be, what is the experience in the Southern Hemisphere? And I'll open that up to all panelists interested.
I'll take a stab at that first. I mean, respiratory diseases, generally speaking, spread more in the fall and winter than in the spring and summer. We know that we see this with measles, we see this with influenza, we see this with respiratory syncytial virus, we see this with every respiratory disease. We don't actually know the principal drivers of this seasonality. There are hypotheses that the K through 12 school calendar is what is the engine of this, but there are also hypotheses about humidity in the air. And there's various hypotheses about COVID-19 and seasonality. And the answer is we still don't know for sure. I mean, one possibility is because this is such a novel virus, there won't be any seasonality in the first year or so, just because the virus sees a human population that's so immunonaive. And so the seasonal effects become secondary in a case like that. Whereas with flu, there's all sorts of cross immunity. There's 1/3 of the population that gets vaccinated every year and so on. So it sort of falls back to a more seasonal posture. So one possibility is that we're not going to see seasonality, that we're going to see what we have now, and it's going to continue through, October, November, December. Another possibility is that what we see now actually is a summer lull, and it's going to be worse. First we were in lockdown, now we're letting up the lockdown, it's getting worse. Then it's going to get worse still in the fall with K through 12 starting and with the humidity becoming more winter-like and so on. In the Southern Hemisphere, it's all over the place, but Brazil is seeing a very severe epidemic right now of COVID-19, very severe. Argentina and Chile are impacted. Australia and New Zealand have been doing somewhat better. New Zealand has been able to exploit its isolation to its enormous advantage, and they were also very smart in quarantining visitors. But New Zealand has these natural advantages of being very isolated. Let's be realistic. So, it's hard to extrapolate purely from New Zealand is winter and right now, which it is. So the most important, so that's my take. It could well be worse than this in the fall. It could well be the same as this in the fall. It won't be better unless we all, do everything we're supposed to, as I said in my opening remarks.
And I would just add, because you brought up seasonality, that this is the opportunity. People are like, what can I do? What can I do? And Andrew and Daniel and I are saying, wear your mask, be vigilant, be hygienic, wash your hands. But I'm going to add something, and that is get a flu vaccination. A third of folks getting a flu vaccine is not good enough. And, we don't want to be in a place where we have a peak flu season like we had last year and COVID at the same time. That's just a huge burden on the healthcare system. And what it does is it takes away care from one to the other, competing care, and also a lot of testing, competition, because, is it flu? Is it COVID? What is it? And so I really think that there is something that we can do, and that's really, make sure that we have good immunization coverage this year.
Absolutely, yeah, and so just to build off of Dr. Neumer's points on the southern hemisphere. So Brazil is through the roof, over 1 million cases, over 50,000 deaths. It's hard to. I don't know what to make of that with thinking about seasonality so much yet, though, because it could just as well be a part of a less well-coordinated response at the national level. There are other countries bordering Brazil that are seeing either a plateau or maybe even a decrease in cases now too. So I think it's a complex situation. Hard to say.
Got it. Thank you both. Thank you all so much. I actually also have a question about specifically with Africa, and any insight that any of you could give in terms of that. That would be great.
Yeah. I don't know, Daniel, Andrew, we're trying to. Yeah, you want to jump in?
I could take a first stab at it. So Africa has a very different population pyramid than other places do, than the U.S. does. It's a young population, and there are lots of other diseases that are very important there as well. So some of the people who we would be seeing dying from COVID-19 in the U.S. maybe have already passed away from another disease there as well. Plus, it looks like there are big differences in the severity of symptoms by age group, which may be related to comorbidities or something else, I'm not sure. But if you have a very young population, I think it makes sense that you would see less severe disease in that population. And I'm sure Dr. Neumer and Dean Bernadette have more to build on that.
I mean, the population pyramids are worth keeping in mind, but the burden in Africa is large, and I know they're really struggling in South Africa, and the prime minister of Burundi died allegedly of COVID-19. There's a lot of data deficiencies in certain places, but don't interpret lack of data to mean there's nothing going on. There's stuff happening, and the COVID, it definitely affects tropical countries. I mean, Singapore has had several waves, and Thailand has gone to enormous lengths to keep it in check and has succeeded so far in keeping it in check. But it's not due to its tropical climate. It has to do with the huge public health efforts that have been expended there. So this is a pandemic, which means global, and it's going to be truly global.
And I would just add, so I do a lot of work in West Africa, but I wasn't able to go to West Africa this year because we were all sheltering in place. And there's a huge amount of cardiovascular disease, especially hypertension in young populations there. And, it's not unusual to see end-stage renal disease and severe hypertension in 20 and 30-year-olds. I think Africa ended up being one of the last, and West Africa, but one of the last places to really start to see COVID. And I think what we're going to see is this unveiling, and it's going to hit. It's going to hit these younger populations again. With this target on their cardiovascular disease factors.
Great. Thank you all so much for that. Moving on to the next question. This actually got 4 upvotes, so it's a popular question amongst the crowd. How can we convince people to follow good public health policy and practice and stop threatening the lives of our public health officials? I think I'll direct that to Dean Bodenal-Bala.
Yeah, first, I'm sure the other my colleagues want to answer this. This is a hard one because this is, as Andrew Neumer pointed out, from the very beginning, this is a disease about behavior, really, and how we experience this disease is totally about our behaviors. And so I'm just going to go back to the fact that in Orange County, we were the model county in the beginning. We quickly sheltered in place. We did the right thing. We wore the masks. We didn't go out a lot. We were very vigilant. And you know what? It made a difference because back in March, we were doubling every 3 days. We were on a trajectory that was similar to Italy and perhaps even New York. We were on a bad trajectory. We shut down, we shelter in place, UCI, Orange County, California, and that curve, that trajectory, it really did flatten, and it held for a really long time while we did this. And a lot of other things were happening, unintended consequences of us trying to protect ourselves from COVID, which, have been devastating, a devastating economy, et cetera. So I know people want to get out there. Also, we are fatigued in terms of being inside in our houses, only speaking to our sort of family pod. I understand that. So this is the tough time because it's beautiful out. It's the summer. We've been in for months. We need to get out. We want to get out. But the critical time for us to do this is to also make sure that we do this with the same vigilance that we had when we were sheltering in place. So here's the thing about public health and public health, leadership. Okay, our focus is on the community at large. We are people that all of our work is population health, the public health, the health of the public. And I sometimes that there is this tension between the health of the community and individual health. And we saw that in HIV, we saw that in TB, we've seen that in history, and we're back to seeing it again. I think about, doing polio work at a time, maybe in 2013, 14, where workers that were going around to houses to get people to get their children vaccinated for polio so we could eradicate it, were actually killed. Okay, so these death threats are not, they're not acceptable, and so it's not a balance. We're doing the right thing for the community, but of course, at some point, their individual rights, do get ruffled, and so I think it's just a balance, and people have to understand what the role of public health is. And the role of public health in Orange County is to keep every person in Orange County safe. Do my colleagues want to say anything?
Well, I would just add, as we've heard, Orange County, we were doing so well for a long time, and we border the worst county in the state in terms of the statistics of COVID-19. And in spite of that, we were doing, really well. We were one of the best of the more populated counties in the state. Our numbers were looking great. And it's just been steadily declining in that regard in the last fortnight or so. And, I know a lot of people on this Zoom call are alumni of the program, and probably a lot of you still live in Orange County or in Southern California. Some of you maybe have moved out of state, but Southern California in general and California in general is not doing as well as it has been. San Bernardino and Riverside counties are doing terribly, doing worse than Orange County. But as Jean Bernadette said, it's a real pity because for what longest time, Orange County was doing great. And now, all of Southern California, particularly LA, Orange, San Diego, Riverside, San Bernardino counties are doing really not so great. And California is not doing as great as it was. And in the whole southeast and southwest of the United States, the cases are picking up. Arizona is bad. We have California obviously borders Arizona. So, it's just nationwide, locally, I think people have just decided, well, we don't have to do this anymore. And that's really a shame, I think.
And don't you think, Daniel and Andrew, that there's also a sense that because we did so well, maybe it's really not going to happen to us here? I mean, one of the things that I'm from New York, and I speak to all of my friends in New York, and there's not one person that I spoke to that didn't have a friend or family member that or somebody they knew that was either, ICU, ventilated, or dead. And we have been so lucky here because we have been so good, but now we need to continue, and this is the hard part. So we can turn this around. That's the great part, is that this is a disease that we can actually, all of us, turn around. And maybe, you can't do everything. Maybe it's too hard. I get that. So what I'm going to challenge everybody here to do is to do one thing that they really don't want to do, but to one thing to be vigilant, wearing that mask or washing those hands, or maybe, I'm going to take out, I should say, from the restaurant tonight. I'm going to do that because I think if we each did these small steps, we could get hold of this. We're at a critical point now with cases, a critical point again. And that trajectory can go right back up, or we can flatten it. And it's Andrew and myself and Dan and the faculty of, public health and UCI Health. We can't do this alone, or everybody has to do this together.
Yeah, I'm a bit baffled by some of the behavior. It does. I mean, I guess it doesn't completely surprise me, but it is a little bit shocking. I do think it's similar to a situation where you have people who've never been affected by the diseases that we can easily vaccinate against. And so there's complacency, right? It's different if you've actually experienced the death of a child. You don't think twice about getting a vaccine for the rest of them, yeah, if you can. So here we haven't yet gone through the terrible situation that Lombardy, Italy went through, that New York City went through. And so it does feel like there's some real complacency. And then just second to that, I just feel like just we need to not be so selfish. It's not just about you and whether or not you as an individual are worried about getting sick from this disease. You wear that mask to protect other people too, right? Like be a good member of the communities, right? Like take care of your community members.
Right.
Great. Thank you all so much for that. Moving on to the theme of testing, this questionee asked, currently there is a lot of confusing messaging around the national strategy with COVID-19 testing. For example, the southern states' infection rates being underreported, the White House is winding down on testing measures, EU considering travel restrictions. Can you clarify the state of testing and help us understand what is going on? I could direct that to Dr. Parker to start off.
Yeah. So the easy answer is that there's not really a coordinated federal policy on any of this. So it really boils down to what's going on more locally. It kind of feels like, I mean, we are a federation. You see the same thing happening in Brazil. So the federal government kind of puts these things on the states, and then the states turn around and put it on the counties, and then it trickles on down that way. But as far as I can tell, we have tests now. Testing has gone up throughout the county. I think there are still places where probably people have barriers to receiving testing, but it's not as bad as it was at the beginning. But there's still a lot of confusion because between what the tests actually mean as well, and where you're getting the test, where you can actually access it. And I guess it's important to split between the serological tests. So these are tests that tell you whether or not you've likely had an infection in the past, and the tests that tell you whether or not you actually have an infection right now. That would be based on either DNA of the virus or RNA of the virus, or antigens for the virus. And yeah, so you've got these two big splits. I feel like there's just a ton of confusion over these things, and also federally there have been changes, because at the beginning there was a lot of finger pointing on why we didn't have the tests that we should have had in the United States, and we even had other nations donating tests to us because I guess they felt sorry for us. And as part of that, they kind of eased the process of having tests approved by the FDA. And I think that some of the tests that have now been approved by the FDA are maybe not at the same quality as we would have had in the past if that hadn't changed. So I suppose it was done in the process to quickly provide more tests, but I worry about the results from those tests, because they're not as good as they're not as high quality of tests as what you would normally hope to have for diagnosing a disease. Right? Right. And I could write a book about this. So I'll pass it off to someone else.
I don't have more to add. I mean, testing. There are aspects that the federal government has its hands in, but it's largely been left up to the states. I mean, we are up to speed more or less with the PCR testing now. I mean, Orange County has done over 200,000 tests.
Yeah.
It's, everyone who needs a test should be able to get a test, and if that's not true, then we're not doing enough testing. But at the same time, we're not in March anymore, and I mean, testing is not the limiting factor in the public health response right now. I think getting people to buy into making some small sacrifices is the bigger challenge, and then potentially tracing, which is what is supposed to happen after testing. But testing is per se is not what keeps me up at night right now.
Yeah, I agree. I don't think testing keeps me up at night at this point either. It seems though that, there was sort of this, I have symptoms, I need to be tested. I go to my physician and they don't think I need to be tested. That happened for a little while as well. But I think now people are getting tested. The only thing I want to make sure of around the county as a whole is that there's that everybody has access to that testing. So there may be testing sites that are underused and testing sites that are at capacity every day, and that has to do with the density of the population around those sites and how many people should be tested. And so that's the only thing that I think is tricky, but the actual number of tests I think is absolutely right. And I'm sure that there's another question about contact tracing coming up, so I won't say anything more about that.
I had a couple of other things I wanted to add too, actually. So I think there's some more confusion. There's also confusion with the serological test, in that I believe some people think that if they come back positive on a serological test, that they're safe from reinfection. And I hope that to be the case. But the truth is we really don't know. So if you've had one of the serological tests that came back positive, don't feel like you're necessarily safe from getting another infection. Still, please wear the mask, practice proper hygiene, be careful still. So I hope that's clear to everybody. And then just leading into, I don't know if there is another question about the contact tracing, but testing alone, I mean, it was really frustrating seeing the lack of ability to get a diagnostic test at the beginning. And so that you heard lots of people saying we need tests, and it was true. But testing alone is not going to get us out of this, right? Like, you can't just test your way out of this. You got to be able to react. It's like if that test comes back positive, then what, right? Because that's not the end of the story. So.
The only thing I would add to what Daniel just said, and then we can maybe move on to the next question, is that the serological test, antibody positive, as Daniel said, we don't know what that means, where the rubber meets the road. We presume it means immunity from reinfection. And it must mean that at some level, but we don't know how long it lasts, and it could last as little as a few weeks. And so, we need to keep that in mind. And I don't want to make this a boring lecture, but remember from those of you who took my class, the predictive value positive curve. The predictive value positive is quite low when the prevalence is low, meaning essentially there's a lot of false positives. A positive antibody test, particularly one that wasn't also, that's not in the wake of illness, is fairly likely to be a false positive. So, and that will remain the case until the prevalence gets higher. There's still a lot of unknowns out there, and everyone needs to mask. I don't want to hear any excuses like, oh, well, I have a positive antibody test. Each of us wearing a mask in public, a facial covering, it doesn't have to be a fancy respirator, something over our mouth and nose. It sends a message that this is normal for now. And it reinforces the positive message that we're in this together. We need to cover our nose and mouth in public. And, it will also lead to milder infections because it puts you on the correct side of the dose response curve.
Right.
Remember, 1,000 viral particles is approximately the infectious dose of SARS-CoV-2. And, when you're breathing in someone else's sneeze or whatever, you get anywhere from 100 to 1 million of those virions. So you want to keep yourself on the low end of that. You want to get 1,000 or preferably below the infectious dose. But if you are going to be infected, a lower dose means a milder infection, which means that you're going to survive. You're going to not be in the hospital. You're going to be sick for a few days, and then you're going to recover, and you're going to have the same immunity as if you had a more severe infection, but you won't have all the sequelae and the hospitalization and so on. So masking reduces cases, but it also creates milder cases. So, the masks aren't perfect, but they don't have to be perfect. They just have to be good enough. And that's all I have.
You're masking enough or all the time when you start watching television, and you have to keep saying to yourself, no, they don't need masks. This is the television. So.
Yeah, definitely. Awesome. So we are moving on to more of a local question. I know we've been speaking nationally and globally, so many questionees have questions about what we're doing in our own community. So one question asked, is UCI working with the city to establish local testing? And I could direct that to Dean Bodenabala.
Yeah, so we have been from the very beginning working with Orange County Healthcare Agency and working with local mayors and governments and working with the community organizations, the community really throughout the county. We started off by working, and Daniel and Andrew were part of a small core group that were brought in by the healthcare agency to help model the disease way back in February and early March, and to try to understand, when we would be at this critical point where we would be at capacity in terms of intensive care unit beds and ventilators. Luckily, that never came at that point because we were able to flatten that curve. And so that was really the first thing. But they wanted us to think about what's the future, what is forecasting, if we change our behavior, how does that work? So we've been working with them on that. They were really interested, and we still are working with them on this surveillance, right? So surveillance and surveillance or antibody testing gives us a population level of how much a certain population has been exposed to a disease like COVID. And so if we did surveillance and it came back at 5%, then we would say, well, 95% of the population is still vulnerable to that disease. And so we're doing large surveillance, not only of the county, so we're in the process of a 5,000 person finger prick sample across the county, but we're also doing surveillance for first responders, that's just beginning, and county-wide healthcare workers. We've also been involved, and Daniel might want to say something more about this, in working to develop a equity-based contact tracing workshop. And what will follow is that we will be training, we will be increasing the training for Orange County, for UCI, and for community organizations. Daniel, if you want to say more about that.
Yeah, just quickly. So the idea is we needed contact tracers a year ago. We're still behind, but now is better than nothing. So we're going to train a cadre of contact tracers, and the goal is to do this because it can be difficult to contact people, especially if you're not from the community. So if you're somebody like me and you're trying to go into a community where it's primarily people of color, then you're an obvious outsider. You're not from there, so people might be a little bit standoffish in responding. So the idea is to get people from the community trained in contact tracing and case follow-up and that sort of thing. So we're working with community-based organizations and partners at Orange County Healthcare Association to try to get this set up so that we have a big group of people who can do this for us.
And then Andrew's also been doing some interesting work in mortality excess, and I don't know if you want to say something about that.
Well, thank you, Bernadette. Yeah, I've been looking at mortality in Orange County and actually in many locales. I mean, the important thing to remember here is that mortality, like so much else, is something we're going to understand better in retrospect than in real time. And mortality in Orange County has been, I would say, modest, but I mean, not so modest. There have been 273 deaths to date, but there probably have been approximately 100 more than have been recorded as COVID. There are deaths that occurred, heart disease and pneumonia that have been occurring that, look suspiciously too high. So even when you take into account the 273 deaths that have been recorded in the county, we have more deaths than a simple model would predict. And one question that people had early on was, well, will other deaths decline? So this is actually going to be nothing to worry about because no one's going to die in a car crash because nobody's driving anywhere. Well, since March, Orange County has had 56 more deaths than the same period last year. So that's actually fewer than you would guess based on 273 COVID deaths. But this idea that we're somehow going to be, in the bonus is just not panning out. And I mean, that was something that I never thought would pan out. This was an idea among people who don't study mortality, basically. But so I mean, mortality, every death certificate, every number of deaths that you see is a tabulation of death certificates, and every death certificate has a cause of death. And the cause of death won't always say COVID. So we're going to have to understand this in retrospect, not in prospect. The 120,000 deaths that have occurred nationwide is, in my opinion, a lower bound, not the actual number. And so, this is a COVID-19 is a disease that is definitely, kills people.
Great. Moving forward, one question he asked, what resources are available from UCI to inform the public? And I'll open that up to all of you.
There's a website.
There's a great COVID website, and there are, we're working in so many ways, UCI, with the public out there. Sue Ellen Hoffer she had gotten an NIH rapid response grant to coming up with the most effective type of health communication in different types of communities and settings. We've got, there's so much. We're writing op-eds. There's so much out there that we are doing with the community. that, you know, the resources are all over the place. I really feel very strongly that UCI feels that, you know, we are just an absolute huge part of Orange County community, and that, you know, that's very, very reciprocal. I'm trying to understand what kind of resources we have. A chat line, we have websites, we have all sorts of information. We're happy to go and provide and give talks to different groups. We've all been doing that. We, of course, are a huge testing center and have multiple sites in multiple communities. We have something that is called the COVID Emergency Fund, which is out of UCI Health. And so investigator researchers who want to focus on COVID from all around UCI, not just in the medical school or nursing or pharmacy, but around the entire campus, have received funds that will really work to better the entire Orange County community. There's a lot of work on depression and isolation. The School of Business is working on thinking through some of the financial impacts. So I think I would say, and I've probably forgotten many things, but we are all about the community, and you just have to reach out to us and we will be there for you.
Great. And I also just got a message that says that the UCI Brilliant Future event series will be sending out a list of resources and a follow-up email as well. So that
Great.
should help as well. And I guess the last couple of questions that we'll ask will be about elementary schools. It seems like it's a really hot topic right now. So one question asked, what are your thoughts on opening elementary schools in the fall? What will be the best approaches and strategies? And I'll open that up.
Andrew.
Well, I'm working with ICTS, the Institute for Clinical and Translational Science, on a task force that's working with Orange County schools to try to design and advise opening of schools. I mean, as things stand right now, I think schools do need to open up again. They were closed in the spring. And, you know, we care about COVID because we care not only about people's health, but we care about people's health because we care about their welfare. And you know, simply, you know, closing schools and closing everything, you know, indefinitely is not going to help people's welfare. And kids need to learn. We need to balance that against risks that, you know, that schools can be an engine for transmission. So it's complicated. You know, from where things stand now, even net of the deterioration of the last few weeks, I think schools need to reopen in the fall. And, you know, I'm not so worried about the kids getting it. I mean, there is the occasional child infection that looks serious. There is the occasional child death even. And there is this Kawasaki-like syndrome, you know, that occurs in children. But these are not very common. Kids essentially get COVID asymptomatically. And so I'm not worried about the kids themselves, but I'm worried about them spreading COVID to household members and to adults who work in school districts, teachers, teachers' aides, you know, other custodial staff, anyone who works at a school who's not a child. So it's complicated. You know, schools are an important part of human welfare, and, you know, we can't just ignore that because a different part of human welfare is in a crisis. And so I think schools can reopen. They need to reopen smartly. We need to, I mean, masking may be, you know, an ambitious goal given, you know, we're talking about elementary school kids, but we need to think about trying our best with that. We need to take kids' temperatures when they're in school because, you know, if they're febrile, then that's, you know, something that parents and the school nurse needs to know. I would not say that under all circumstances that schools need to, or schools cannot be closed down again. I can imagine an absolutely catastrophic crisis, you know, in which we have to go back into some form of what we saw last March. Nobody wants to see a situation like Lombardy, Italy saw in February and March, in which people are being literally turned away from hospitals because the hospitals are full. So we need to strike a balance. I'm I'm not in favor of indefinite lockdowns. I think if right now, based on what we know right now, schools need to reopen, and we're trying our best to come up with a set of guidelines for schools reopening safely. And I'm sure Daniel and Bernadette have their thoughts as well.
Yeah, I think Andrew's spot on this. We can't keep our kids in our house forever. As someone with a 3-year-old, I may not survive forever if that goes on for a very long period of time. But maybe our schools were a little bit too crowded in the beginning, so we need to think about ways to space kids out. And I think some kids, if you're talking about a 3-year-old, a mask is maybe a little bit out of the question. But I think we could find solutions for older kids, for elementary school kids. I think there are some solutions. It could be done. We just have to be smart and be careful.
Right. I mean, we're in a great location because Southern California, you know, from a New Yorker's perspective, does not get cold ever. And so I think we really do want to use outdoors. There's a lot of outdoor. It's easier to distance outdoors, you know, and so we think we need to figure that out. We may need to think through, you know, alternate days to decrease the density in some schools. And then we really have to work with parents and households because children will get sick, COVID or not, they will get sick, but it's the people in the household. Maybe there's someone immunocompromised. Maybe there's a pregnant mom. Maybe there's an 85-year-old, you know, grandmother in the house, and they become really vulnerable. And to Andrew and Dan's point, that's what we really worry about, and that's why we really want to do this. We want to do this carefully in terms of thinking about reopening the right way, because there are all these consequences that, you know, that happen. And I don't think, look, every now and then we hear about a school that's closed down for 2 weeks because there's norovirus. So I can imagine these kind of short temporary closings to do deep cleaning in school. I can imagine that's what we will see. That's what we're also going to see in the workplace as well. And I'm sure that we're going to see a little bit of that, you know, on a large campus like UCI as we reopen in a hybrid manner.
Great. Thank you all so much. It looks like we're almost at time, so I'm going to go ahead and wrap up. I apologize to anybody who asked a question and we couldn't answer it. And we'll follow up with any resources or anything else in a follow-up email once this webinar is over. So thank you again to Dean Bernadette Bodenal-Bala, Dr. Andrew Neumer, and Dr. Daniel Parker for this important dialogue of promoting and protecting our community's health. Thank you to all the attendees for your participation and very thought-provoking questions. We are actually, the day before, tomorrow is actually UCI Giving Day, so please consider supporting to the UCI program in public health tomorrow at our 4th annual university-wide Giving Day. This is a 24-hour campaign, which is an opportunity for those in our community to come together and make a collective impact. So every gift counts, and any link will be given and can be found at givingday.uci.edu. So this event, along with 2 previous Brilliant Future virtual events, will be available on demand on the Brilliant Future in the next few weeks. Thank you again, and zot, zot, zot.